Hello, everyone. My name is Ashley Shirkite. I go by she, her pronouns. I am the Harm Reduction Program Manager for Unified HIV Health and Beyond. I am facilitating the conversation today in regards to harm reduction and our role. This session is going to be with an emphasis on COVID and how these challenges have really helped demonstrate the need to recognize essential harm reduction services and understand the current support services that are available and identify the barriers to service expansion and recognize the importance of harm reduction advocacy. With me today, there will be several panelists. I will have each of them introduce themselves. And then at the end of our introduction, I will ask a few general questions and go through the list so we can get a broader perspective. And then there will be a Q&A session at the end. So if my Grendel is in the room. Grendel, are you there?
Yeah, sorry. I was like, is that me?
Yep, go ahead and start introducing yourself.
Hi, everybody. I'm Gretel. It's actually from a book, so really cool character, however. I am a secondary Narcan distributor and safe injection distributor, and I work in other facilities within the community as kind of doing my own thing with harm reduction and how I use it to get the tools and everything out there to people. You can see it right there. Sorry, I am on a Bluetooth thing with my son too, so he's trying to chime in a little bit.
No worries, this is our new existence now. So next, Lamont, do you want to introduce yourself? Does everybody else hear Lamont? Because I do not on my phone.
No, I think you're still on mute.
Are you on mute, Lamont? Sorry, we're in the office together. I'm trying to do this with clients coming in.
Now, can everyone hear me now?
Yes, yep, we can hear you now.
Okay. You didn't miss much, but anyway, I'll go back over it again. Yeah, my name is Lamont Gore, Outreach Coordinator for Unified HIV Health and Beyond. And I want to thank you. I'm honored to be asked to participate in this discussion today. But I'm also asking anyone who's listening to my voice to question and research anything I might say for your own self-verification. I'm not always correct 100% of the time. So if you have any questions, please don't hesitate to ask.
Brandon, do you want to introduce yourself?
Yeah, hi, my name is Brandon Houle. I work for Michigan Department of Health and Human Services. I'm the harm reduction analyst with the viral hepatitis unit. My role basically is to support and facilitate communication between the now numerous syringe service programs in Michigan. And I'll run my video from now on. I just had to stop it while I changed out of my pajamas and locked the cat out of the room.
And we also have today Dr. Redwood, who joins us as an emergency room physician.
Hey folks, my name is Bobby Redwood. I'm dual trained in emergency medicine and preventive medicine, which is the medical specialty of public health. And I'm the physician lead for the Midwest Alto Project, which is based out of the Wisconsin Hospital Association. I actually run an emergency department at Cooley Dickinson Hospital, and then I speak nationally on medication-assisted treatment, opioid harm reduction, and naloxone prescriptions, and alternatives to opioids in the emergency department.
Thank you. I really appreciate everyone being here, and I want to honor and acknowledge those who cannot because of other circumstances. I think for the first question today, I would really like to understand, what is harm reduction to you and within your field?
Sure, I can jump on that one. Harm reduction, it's a pretty, I've come to interpret it as a pretty broad term. I kind of cut my teeth in the syringe services field. So, reducing the harms from injection drug use to people who are injecting drugs. But really it applies to a lot more than that. And I think my more broad definition right now is just meeting people at the door and opening it. Meet people where they're at and work with them to remove the barriers to improving their health, because everybody wants the best for themselves. But a lot of people experience more barriers to that than others.
Brandon, I love that definition. I also use a broad definition of harm reduction. In medicine, it's not just about opioid use disorder or substance abuse. We use the term harm reduction, talking about hypertension, diabetes, et cetera. It's about mitigating the damage done by a disease. And like you said, meeting patients where they're at. So if someone's not ready to stop smoking, you can still intervene and help mitigate the effects of smoking without having an abstinence-only policy or unrealistic expectations. In the Midwest Alto Project, we talk about the cure for the opioid epidemic, and we divide it into 4 categories. One is limiting the amount of opioids that are out there. So, prescription drug monitoring programs, things like that, trying to get fewer pills on the street. One is alternatives to opioids, avoiding the first taste of an opioid medication. So when someone breaks their ankle when they're 16, is there an opportunity to treat that ankle break without opioid pain control, so you never put them at risk for substance abuse disorder in the first place? One is medication-assisted treatment, which is actually, once people are already using, treating the cravings and getting them off of the medications. And the other aspect is harm reduction. So traditionally, that's been things like needle exchanges, safe injection practices, safe injection sites, and naloxone distribution. But I think there's a gray zone with medication-assisted treatment and alternatives to opioids as well. And so I prefer to keep it broad as well, and meet the patients where they're at and provide the services they need rather than box it into any one category.
Okay. Hi, Gretel. So for me, it's a little bit more humanized, because I get counts of reversals from people that I personally do distribute Narcan and naloxone to. I have a couple very receptive drug dealers actually in Detroit that I will randomly go meet up with when they call me and tell me that, they're starting to run low. I carry it in my car and I hand it out to people. So there's, for me, it's a very personal thing that is all aspects of everything. I mean, it's an unfortunate truth that a lot of people don't feel comfortable trusting the system, and they're more comfortable trusting people that in their kids. I know people who have kind of like safe injection lines set up in their area. That way, if the questionable batch of heroin out on the streets or fentanyl, they, you know, call somebody that could be a couple doors down from them, say, hey, this is what's going to happen, and then they go check on them, and if they're able to do the reversal and, you know, not get the system involved, it worked pretty well for a lot of people. And I really advocate where I can for trying to get that understanding to, I'm the daughter of a psychiatric nurse. I also work in healthcare and mental health and other aspects. So I try to bring that into my work life as well as personal life.
I'm unmuted. Okay. So this is the working definition that I've used. I've used this in almost all my presentations, and this is the one that works best for me. Harm reduction is a perspective or a viewpoint and a set of practical strategies, doable strategies, to reduce the negative consequences of drug use. So we're talking about illness, incarceration, homelessness, unemployment, etc. And incorporating a spectrum of strategies such as syringe access, testing, safer sex supplies, referral information, and listening from safer use to abstinence. So the spectrum is very wide. And I think two of the things that are most important is remaining open and listening, and in other words, hearing what your consumer is trying to say.
Thank you. I really appreciate the various definitions, but how cohesive they all are. So my next question is, what harm reduction focused services currently exist in Washtenaw County? Have you seen an increased need for these services? Brandon, do you want to give a state view, and then maybe and Grendel I'll have it kind of go down.
Sure. I'm, not as intimately familiar with what's going on in Washtenaw County. We have a great organization there, Unified, that we support and believe in their work, and we don't really need to get that involved. But from a statewide perspective, we've seen over the last couple decades a huge increase in young adults with hepatitis C who indicate that they have a history of injection drug use. Prior to that, it was a concern with the baby boomer generation because of the number of lifetime risks and the blood supply, the organ donation supply not being consistently tested for hepatitis C. So hepatitis C in young adults is a great proxy measure for the amount of injection drug use, unsafe injection drug use that's happening in a community, and we see that statewide. From a national perspective, we had the outbreak in Indiana in 2014, the HIV outbreak. Michigan had 11 counties. The CDC studied what led up to the HIV outbreak in Indiana, which was primarily driven by injection drug use. So the CDC compared risk factors from counties around the US. Out of the 200 and some highest risk counties in the US, Michigan had 11 of the highest risk counties. And that's the highest risk for a similar HIV outbreak. And looking further into that, we see even a higher risk for hepatitis C outbreak across the state. And up until 2017, there were only 4 syringe service programs in the state of Michigan. And those were mainly in metropolitan areas, so Grand Rapids, Ann Arbor, Ypsilanti, Flint, and Detroit. So the state, up until just a couple of years ago, very, very underserved in harm reduction services for injection drug users. And even at the rate, there's about 30 funded programs right now with about 65 syringe service program sites across the state. Even with all of that availability, still drastically underserved. The entire state's drastically underserved. And we can tell by the amount of syringes that are going out and by the estimates of injection drug use rates in the communities. So yeah, in the state, there's 65 sites where people can access syringe service programs right now, but still that's not enough. They're not utilized enough. And, as was mentioned before, people who are injecting drugs have a very real fear of connecting with systems that other people don't have that fear of connecting with, because over the drug war, people who use drugs have been incarcerated, targeted, all kinds of negative outcomes from engaging with these systems. So it's great to see more services available, but still very underutilized.
Thank you.
So, following up on what Brandon was saying, in Washtenaw County, we've been supported by other agencies. We've been supported by the Washtenaw County Health Department. We've been supported by community mental health, in Washtenaw County. And we've also been able to align ourselves with other agencies, Packard Health, and the physician there, Dr. Sethi, and with Avalon Housing. Avalon was one of the pioneers in housing individuals who were currently using. And we've been able to, to work with them. So, the community partnerships are really important in, in the success of our program. And several of the programs that I just mentioned refer individuals to us for our services, our harm reduction services. I'm not sure how much that happens in other areas. So if someone speak to that, probably a good idea.
Kendall?
I'm sorry.
Washtenaw County?
Can you clarify that? I'm sorry, I couldn't hear.
What services are in Washtenaw County, and kind of what are the barriers that you see as a Washtenaw County resident?
So, ironically enough, earlier after you and I got off the phone, I was talking to one of the veterans that I work with, and this is a gentleman who served in Vietnam and continued going down to Central America for like almost 20 years full service. And a lot of the current programs that we see in place, like weaning off of medication, they aren't necessarily being targeted for those who are going to abuse the system. And he said that it's been a constant struggle with his doctor because just the quality of his life has gone down, and he finds himself going to outside agencies to get something just to help improve his quality of life and just try to get through the day. And I think that it's it's hard to recognize sometimes when we have an inherent prejudice, and I even personally find myself doing it, and it's a constant correction for me where, you know, you kind of divide something without even realizing that it happens, and it impacts us, and how we see people and how we treat people. And I personally, back when I was actively using, I would be hesitant sometimes to go. I had a medically necessary pregnancy terminated. It was life-threatening, and I had to go to a Catholic hospital to receive treatment. And it was very clear that, you know, the opinions of the staff around me, and I was very upfront, you know, working, again, my mom was a nurse, and I know as soon as my blood is drawn, they're going to know what's going on. And you lose credibility in the system when you admit to being a drug user, instead of saying, okay, let's take a step back. How can we help you get through this challenge? And I mean, had I not gone in, I would have gone septic and I would have died. I mean, I was on 3 different types of IV antibiotics just to get everything out. So it was, even knowing what I do of health and healthcare and myself, I was still hesitant to go in and get the treatment that I needed. So I think that we have to acknowledge that, you know, inherently our system it's flawed, like I've heard discussed here so much. And I think that's such an awesome thing that we're acknowledging, that we have services that are underutilized and people who are afraid to get services and resources because of how it can impact their life otherwise. They're afraid to get alternatives like Suboxone, Subutex, or Methadone because they don't want that stigma labeled to their health records for the rest of their life, and not be able to get medication in the event that it is needed, or be looked at a certain way as soon as they go in to seek services. And I mean, there's a lot that we could do differently, and but that's in a lot of aspects of life too. So I just always want to, I always try to stress that to people that, you know, it's a gray area, especially when it comes to needle exchange programs and stuff. I've seen people go 2 weeks using the same needle rather than go find a place to exchange services. And I shudder thinking about that, you know. So I think that other barriers include not knowing comprehensively how to get services and where to reach out, what programs are safe as far as judgment-wise to reach out to. And naloxone and like Narcan access is pretty good, and I mean, they're even offering it CVS now with opioids. If you just want Narcan, you can ask and they'll give it to you. So I think that seeing that is impressive. I've personally had probably since the pandemic began, reversals have drastically increased because of just the quality of supply, and being able to, even in the pandemic, go out and get that out there, I think was very, very big. And yeah, I think that's personally all I have for right now. I will chime in if I hear a point that I want to speak up on. Thank you.
As an outsider, I'm pretty impressed with the services offered in Washtenaw County, based on the overview that Matt provided me before the program. In particular, the root team with the peer response actually going to emergency departments, that is a special thing. And naloxone on ED discharge, that's a very key practice that's really worth investing in. And then hearing that naloxone is available at CVS is just incredible. In my experience, the Sometimes you look online and you'll see 30 services offered, but when you go to community, it's really one or two. It depends on, you know, the funding and the sustainability. And less can sometimes be more if there is if the central hub in a community that's really providing the services, investing in that hub rather than 20 separate programs that might not be the most sustainable. And then I heard a couple times already the importance of reducing stigma and then also encouraging access to services. I'm on the East Coast now, and I do feel, you know, we're in this era of stigma around calling 911 for opioid use and difficulty kind of getting through to law enforcement at times. Traditionally, emergency departments have very strong relationships with law enforcement, and sometimes that's actually a good avenue for getting the ear of law enforcement about destigmatizing opioid use disorder, perhaps even getting a departmental standard not to prosecute someone who calls 911 for an overdose. And so that might actually be a good use of emergency department leaders, whether it's EMS or the director or hospital leadership, is to facilitate conversations with law enforcement about what the community standard should be. You don't always open that door with pleas from the community or even pleas from city council, but the hospital tends to have a strong relationship with law enforcement and can sometimes establish that standard on the sort of internal end.
I really like that perspective, because it is, when somebody wakes up from an overdose, you know, typically they wake up assuming law enforcement's going to be involved, and it can negatively impact their care they're receiving at the emergency room, and that's something we're seeing too. We're seeing a lot more non-fatal overdoses, people leaving against medical advice from the ER, refusing transport to the hospital. And those are services people need, but there's been that very well established relationship between the ER and the law enforcement, and you know, shifting away from that's going to be a negative interaction for the patient. You know, getting that through and communicating that clearly is going to take a lot of very conscious effort, I think. But I do like the route that's. Yeah, the route, going that route. Unfortunately, right now, people are still very, very skeptical of any system, any emergency system when they're using drugs. It's unfortunate. But I did want to also follow up on you know, Grendel saying something about COVID, the COVID and the pandemic. You know, at this point, you know, this wasn't so just a couple of years ago. Like I'm saying, it's going to take a lot of change to change the public perception of that relationship. First responders and emergency rooms. But even the state of Michigan has drastically shifted its views on harm reduction. When I was working at a needle exchange, you know, 3 years ago, we had almost no state support. We had people saying, you know, patting us on the back and saying, "Great job, what you're doing there. Show us the data. Show us it works. Well, good job." It's very different at this point. How far the state has come. Because during the pandemic, when everything shut down for the stay home, stay safe order, the governor's office actually signed a letter stating that syringe service programs were an essential service and were allowed to remain open. People were allowed to legally travel to and from them. Workers were protected. So that's huge for the state to get behind harm reduction in that way. And most of the programs did. They saw from their perspective that they were needed. They needed to stay open. I had people sending me emails saying, "Yeah, we're staying. Are we essential? Well, it doesn't really matter. We're staying open anyway." And we saw the evidence from that too. We saw the evidence that service was needed because we saw the same amount of syringes go out the door during the shutdown for the pandemic that we were seeing prior to everything being shut down. So I think, you know, increasing these services is crucial. And I would love to see more in Washtenaw. I'd love to see Unified continue to grow, and these other harm reduction organizations that I'm not as familiar with continue to grow.
Yeah, if I could, I just wanted to follow up on some things that, you know, were being said and touched on. One of the, well, there's a couple of issues that I see have not been confronted. And when we talk about stigmatization, see, stigmatization comes in different forms. It comes family stigmatized, you know, people in the family that are using. Community stigmatization, law enforcement stigmatization, and the medical community stigmatization. And when I say this is that, you know, I've studied harm reduction. Okay, I have not studied law enforcement. I have not studied, you know, medicine. And my point is that a lot of, you know, people in law enforcement, they've heard the term harm reduction. They don't truly understand the purpose of harm reduction or the effect of harm reduction and how it affects them in, you know, in doing their job. I get different feedback from, you know, my consumers who wind up going to you know, the emergency room, how they're treated there. One extreme case, I just had an extreme case where one of my consumers, instead of going to the emergency room, wound up losing a finger because of the fear about going for service. My point is that, you know, there's a lack of training and information sharing. I believe that is, you know, important. We ask a lot, you know, from these other professionals. We ask, you know, law enforcement. And I understand law enforcement, you know, we ask them to do everything, and they can't. And, you know, but at least, you know, there's some things that I think could help them, you know, understand what it is that we're doing. Number one, I'm a firm believer in the ACEs theory. I believe that should be definitely, you know, something that's pushed for law enforcement, because if I grew up in one community and I'm asked to serve in another community and I have no background in that community, I don't know what the forces are, you know, that have caused that community to be what it is. And how do I react to that? Do I react, you know, knowledgeably, or do I react, you know, with, you know, the information that I already have at hand? Same thing with law, with the medical community. Okay, you know, so until there's a better understanding of what it is that harm reduction really is trying to accomplish and what we do accomplish, I think we're going to always have, you know, this misinformation from, you know, the legislature, you know, from law enforcement, you know, about why should we care?
I absolutely feel that, Lamont. Like, I was kind of getting ready to address a little bit of the family stigma and the community stigma myself, because I was like, that's just not something that we've really talked about yet, but it is a thing. I mean, I have, you know, a pretty significant amount of time of you know, being sober and being, you know, not using, and just occasionally having, if I know it's going to be a rough period of time for me, maybe having to go and, you know, get a couple Suboxones. And I managed it very, very well. And even the tools that I use, because I did sustain an injury at one point, and my husband and I had an agreement where if I felt a certain way on a certain day, he would take my medication with him or hide it and leave one or two out in separate places. And, you know, I felt smart about that. I was like, you know, this is a good way to recognize how my personal feelings translate into I'm stressed and I could want to use today. And it was literally like, oh, well, you shouldn't be taking that. Well, I probably couldn't do what I needed to do with life. And if I'm not able to help myself and I'm not able to do what I need to do for myself because I don't have a good quality of life due to pain, then, I mean, it becomes a self-perpetuating cycle where you end up like getting depressed, and then you have all of these people looking at you just a certain way, and it hurts, and it hurts to go into the hospital knowing that you need treatment, or that you've been doing your best and you had a slip and you're gonna be regarded a certain way because of that. I currently have a friend who is in danger of losing use of his arm. There's like in Washtenaw County, there was a mandate where you weren't supposed to be picking people up if they did not commit a probation violation. It was just like a substance use thing. And he had just gotten out of the hospital after having strep and getting a staph infection in an IV site. And it was pretty severe. I mean, he was in hospital for almost 2 weeks, still under a doctor's care. And his phone gets shut off for a day, and now he's in Washtenaw County Jail quarantined at Hogback for 14 days. The doctor refused. He's since been let go. The nurses ended up ratting him out, but the doctor refused to go down to the quarantine unit because he was afraid of getting COVID. And his arm swelled up so significantly that even the judge commented on it during their video Zoom. And he's like, all of this, now he has permanent risk of losing, use of that arm or having permanent damage. His first referral to the doctor referred to see a surgeon to see what they could do to save usage of his arm. All over a missed drop, and how the system regards him, and how even, the community kind of regards him, and the people who are supposed to be his advocates in the system, his caseworker, his probation officer, these are supposed to be, especially I feel, the caseworker, and we haven't an honest that falls onto people in our legal system. And I also speak as my mom was the psychiatric nurse with the state of Michigan, working with criminally insane people for the last 20-something years of her career. So I got to see a perspective on even how dedicated staff within our state regard people in prison as less than human. And my mom would literally receive threats for doing what she needed to do when their rights were being violated and speaking up. And it's a very close knit, and I feel that at times it applies to all of our jobs. We tend to kind of focus in, like Lamont said, on what our jobs are, how the knowledge that we have personally at hand at that moment, instead of working to expand ourselves and expand our knowledge and make sure that we're truly coming at it from a human aspect, and just looking at somebody and saying you're not less of a human being, regardless of if you're in jail, if you're on drugs, if you have Hep C, you have HIV. I mean, you're not less. You don't deserve less than me because of it. It's not a competition. We're all trying this together. With the pandemic, I mean, I completely agree with what Brandon had said about how awesome Michigan's response was, and from what I know of the Department of Community Health beforehand, working in crisis residential, and the pressure that we do put on our police officers to, if somebody left a crisis residential program, you had to call the police. And this is a person in crisis, in mental health crisis, probably a little still trying to tirade up on medication and not necessarily the most stable. You're acting them like they're being asked to interact with police, and sometimes they're asked to be the calm ones in that situation. And I've literally watched it happen where the police come in kind of jacked up a little expectant that they have to come over to the crisis residential program, and there's an incident where somebody's starting to get rough with staff or get loud, and they come in and they make it worse, and you regret that that's company policy, that you have to call the police when that happens, because it makes people less likely to want to come to a crisis residential program and seek out mental health services, which, trauma is kind of a huge gateway to drug usage. And if you can't address that trauma at the source and try to figure out what to do with those feelings, and I speak from experience on this, you can't be self-aware enough to identify how to move forward and still have a quality of life without letting those perceptions overcome you. And trying to overcome that stigma within the community, within your interactions, law enforcement, healthcare services, every aspect, you have a stigma attached to you, and it affects how safe and comfortably you feel you can address services and get services. And I would love to see more impact with police, where our interactions weren't always ones of how could this potentially go wrong, and it's a thought. As somebody who actively works in healthcare and mental health, it's a thought when we end up having to call the police. And there are situations where they come in and you get the right officer and you have the right relationship with that officer, and you're able to do a lot more good than bad that day. And that's a win on those days, So I love that you brought that up, and I wanted to absolutely agree with Brandon on the piece of how awesome Michigan was with its response, because we really did rock that out for sure.
Thank you, Grendel. I really appreciate that openness and rawness. I think a lot of times we do need to reflect upon ourselves and within our own practices. It's especially hard in healthcare or law enforcement to kind of get that feedback, but it's something we all need to hear, that the realities of the people who are most affected. I do want to open it up to question and answers from the audience and kind of look at how can we take this further into actionable steps that would make a difference within the county, especially for people who are actively using and want to stay safe.
So I have a question for Dr. Wedwood real quick. Can you kind of walk us through a little bit of what harm reduction looks like in the ER that you lead, and what kind of buy-in did it take amongst hospital staff to get to that point that you were at, in terms of doing some of the reductions you guys are doing now?
Sure. So I've been in my position for a year, and I actually inherited a pretty good program. So we live in a progressive community in Western Massachusetts, and I would say the services offered are pretty extensive. So we have in-house case management, social work, and then a crisis service organization. And crisis services is 24/7, and they will come to the ED and meet people in the ED. And offer services like drug use counseling, naloxone access and training on a walk-in basis, referrals to substance abuse treatment programs, and medical care for sequelae of drug use. There is a local, it's called Tapestry, a local service that has syringe pickup for free 24/7. It is not a safe needle injection site. That is not taken root on the East Coast largely. And then there's used syringe disposal on site and in multiple community locations. Then in terms of actual ED practice, one thing that I would love to see more of is just the awareness of instructions, discharge instructions, or patient level education in terms of safe practices, safe injection practices, things like avoiding using alone, being cautious if you haven't used for a while, you're more likely to overdose in that instance, avoid mixing substances. If it has been a while, do a tester shot, or even if it hasn't been a while, to make sure that the substance you have is what you're used to having. Having an overdose plan, not being afraid to call 911, which the stigma, I would say, in our community is not as much a problem. Actually, law enforcement seems quite enlightened in that respect. Always using new equipment and never sharing old equipment, and then avoiding things like licking needles or using non-sterile water. Always discard your cotton after every use. Things like that with just basic instructions actually go a long way, and the ED interaction is often a powerful time. We do routine screening for Hep C, HIV, pregnancy, things like that. I think that's a role that many EDs play. And then in terms of our naloxone discharges, with the hospital actually has a charity program. So that's a real question, is whether people, you can't just give a prescription, whether people are actually going to fill the prescription. And that goes not just for naloxone, but also for buprenorphine for medication-assisted treatment. And so if anyone interacts with providers out there, my advice is a few things to write on your prescription is that you may substitute strips for tabs, you may use generic, and then no refills. There's a lot of insurance barriers to filling prescriptions, and if you don't have those 3 things written on there, that can sometimes be a barrier. So you give a prescription, but it doesn't actually get filled, despite someone trying to fill it in the community. And then, in terms of, I think an ideal situation would be a co-located space. One of the problems with treating opioid use disorder in the emergency department is that a lot of our services, like case management and social work, will be available during bankers' hours. They'll be available from 9 to 9 or 9 to 5. And that has to do with hospital finance decisions. They'll choose to finance these services when the most patients are in the ED. And that makes a lot of sense for medical patients and nursing home patients. But when you're talking about substance use disorder, these patients often come in after hours, between the hours of 9 p.m. to 9 a.m., when those services aren't necessarily available. And so we do have a process to put an order in after hours, where case management or social work will actually reach out to the patient after hours if they need enhanced services that crisis services can't provide. And then at the end of the day, a lot of what we're talking about really is about medication-assisted treatment and the role of normalizing medication-assisted treatment and buprenorphine within the emergency medicine community. And so our whole group has X waivers and the opportunity to prescribe buprenorphine when appropriate, which is really most times when someone's suffering from opioid use disorder. And that's something that I think we as a specialty could get better at as well, is just breaking down some of those barriers. I would like to see the X waiver requirement removed entirely. It's you've probably heard this before, but the poison, the opioids themselves, are easy to prescribe, and the cure, the buprenorphine, has many hoops to go through in terms of prescribing. And so it's a little bit of misaligned incentives in that respect.
We do have a question. I'm just going to read it. It's wondering if Washtenaw Police Department has social workers on payroll, and do the panelists have any thoughts that a social worker/police officer partnership would allow for better relationships with law enforcement, which can enhance harm reduction? Lamont, do you want to speak on this, since you have a good community relationship?
Oh, am I muted?
Audio. Okay, go. No, I think you got to do it with the phone.
Okay, am I back?
Yeah, go ahead. You can take it.
Okay, so the Washtenaw County Police Department, and I really don't want to speak for the Washtenaw County Police Department. I do know that there are programs set aside where there's references to harm reduction programs, when a person is either contacted by law enforcement, or law enforcement has to respond to a situation at a hospital or whatever. How effective and what those referrals are, I'm not really sure. Like I said, I cannot remember one incident where the police, referred anyone to our program. I have trained, police departments in using naloxone and applying that. But that was, those were compulsory trainings. A lot of times, the police departments were not that, enthusiastic about having to use it. Although I did understand later that once naloxone, was used by that department, then it became more acceptable. So again, it comes back to my point of, additional training, not seeing, the general population as an opposition. So anyway, that.
Testify, brother. I kind of think that's a key word there too, is the opposition. I kind of say that it's not a competition. And I think that that's an important point. Is there's a lot of viewpoints where people look at it as an opposition. Why are people getting Narcan when insulin is so expensive, or this is so expensive, and they don't realize that naloxone is actually part of in a lot of cases, a class action lawsuit against pharmaceutical companies. They don't know the research and the reasoning behind it. So it's turned into a tool against the community where it's used as a opposition, and I think that's a huge point that often.
I mean, I think the bigger point with this, when thinking about the community of people who uses drugs, is that no matter how many services we offer, social services, syringe service programs, we could have a syringe program in every city in Michigan. It could be completely accessible to everybody. We could give out millions of naloxone kits a year. It could be accessible for free to anybody in the community. But I think, the stigma is always under considered. People, even if we had all those services readily available, social worker, naloxone, syringes, there would still be people who get hepatitis C. A lot of people would still die from overdose. People would still lose limbs to sequelae of injection drug use, endocarditis and gangrene and all that stuff, because drug use itself is so stigmatized. It's internal, it's external, it's systemic. When we have a system that the police are involved with my life because I put something in my body, there's always going to be a reluctance for me to engage in services or to admit my drug use. There's always going to be a reason for people to use alone where they can't be revived by Narcan if they're afraid of their use getting discovered. When conversations happen like about drug testing for food stamp recipients, I can lose my food because I use drugs. When those conversations are happening and when that's something that people are considering, there's always going to be a stigma there. There's always going to be a reason for people, whenever people have a reason to hide something about themselves, there's always going to be a danger because they're not going to engage with services. And I think until that bigger picture changes, we're still going to continue to see negative impacts on the health of our community members until that bigger conversation happens. When you talk about things like medications for opioid use disorder, we could make Suboxone available to everybody in Michigan for free. Even if we did that, there's still people who would not take you up on the offer because it's still out there, currently, that people can lose their medications for their opioid use disorder because they relapse, they use opioids. We can restrict somebody from getting, well, not we, yes, we. There's still a Medicaid restriction in Michigan for people. You can't get treated for your hepatitis C, for this disease that can kill you, because you use a drug. We don't treat other diseases like that. We don't treat things like heart disease. We don't, you know, our medical community does not say, hey, if I see you at the drive-through at McDonald's again, we're not doing your heart surgery. But that's still a very real thing in the lives of people who use drugs. You can be denied medical services. You can be denied your freedom. You can be denied other services. And so I think, you know, no matter how many services we offer, we're still not addressing what's really going on. That's the stigma that these, and that's an attitude that prevails, and it's killing a lot of people, and it's causing a lot of damage.
Brandon, that's so key. You know, there was in theory mental health parity and behavioral health parity, but it didn't actually get operationalized at the state level. And some states have done better than others. I don't know what the climate's like in Michigan, but it sounds like there's room for improvement. Wisconsin next door, Representative John Nygren has a legislative agenda called the Hope Agenda. And he's actually a Republican. He's very open about the story of his daughter overdosing, which sort of brought him into the fold. And every year they release a series of laws related to opioid use disorder and destigmatization, et cetera. But one of the big successes has been actually achieving mental health parity, and they're still not there, but they've made great steps in terms of getting services funded at equal reimbursement within Medicare and Medicaid. So if anyone has reach in the legislative sphere, you can refer them to the Hope Agenda in Wisconsin and Representative Nygren's work, because I felt like the needle on stigmatization, it did sort of follow the money. And when the reimbursement levels were truly on par is when we started to see clinics that looked more, you know, opioid use disorder clinics that looked more like cardiovascular disease clinics or diabetes clinics. And when we started to see services co-located in hospitals and see some of that stigma fade.
We have 1 minute. Do each one of you want to make like a kind of final closing of what you think would move forward in terms of your field and how to remove the stigma, but also make more of an impact on illicit drug poisonings?
I can end by responding to Matt's question in the box. He said MAT is great in the ED, but what about referral to social service programs? And just a general awareness, a social worker in the ED, every ED wants this. This is like our dream. So it tends to get funded in EDs that are greater than 40,000 visits per year. So your moderate to large size EDs, just because it is a staff salary. And so in small community EDs, you will routinely not see access to a social worker. And the power of that warm handoff is really important. And so I don't know the solution to that necessarily to get social workers into smaller EDs, but that would be a great project for any community and would always be welcomed by emergency department staff.
No, God. Okay. Do you want to go or do you want Lamont?
Yeah, real quick. Always look at the person in front of you, not the drug that they use. The person is not the drug, and that's what a lot of systems seem to focus on is the drug the person uses. But the person in front of you, always look at the person.
Yeah, the last thing I'll say is this. If we try to operate from this premise, and this is just harm reduction based premise, that individuals will continue to use substances until they determine a need or develop a willingness to change. These individuals deserve the right to remain as safe as possible while continuing to use. That's basically what we try to do. We're trying to keep people alive until they decide that they're ready to change, or even if they don't decide to make that change. It's as simple as that.
Thank you. And then Brenda, do you want to have any closing remarks?
I think that both Brandon and Lamont kind of made the point that I would wanted to make is when I say we, I mean we as drug users, because I mean to this day I consider myself a drug user, and you know we have our issues with the system, obviously, and it makes us hesitant to come and seek services. And I do speak when I say Unified is phenomenal, by the way. I thank you guys. And we just, anybody coming before you wants to be seen and recognized as a human being, because that's what we are. I mean, nobody out there is a Martian, and nobody out there is a swamp monster. They're a human, and they deserve to get the treatment that they need without being afraid to get it. And there's been awesome key discussions, I think, on here about how we can achieve that. And it's systemic, it's inherent, and we really have to focus on that piece before we can make the difference. And I heard a lot about what the doctor was saying about what he has going on in Wisconsin, and I think that that's an awesome step for an emergency department. And it's kind of refreshing to hear that that's how it's being treated. So let's, in all of our professions, keep working towards keeping people alive, regardless of if they're shooting up, if they're snorting, if they're doing Suboxone. Doesn't matter. We want to save them. We want them here with us tomorrow. They're our family members, they're our community members, and we owe it to themselves, like to ourselves and them, to do better with what we're doing, and to constantly strive to make sure that we are meeting the standards that we would want to be treated with when we go in to seek services, regardless of what those services are for. And thank you again for the opportunity to speak. It's pretty cool. It was nice meeting everybody. Thank you.
Thank you so much. It's we have to honor how much our communities are keeping each other alive when system failures happen repeatedly, and only look at it as an opportunity to move forward. So I'm going to wrap up this presentation, and I think this will be it for the day for the breakout and having a closing.
Yep. So actually, we just did a small closing before, so we didn't have to try to shuffle everybody back out to the other Zoom meeting. So thank you everybody so much for attending this year's summit.
Thank you.
Have a good day, all.
Yep.
Thank you.